aware, ERA meeting is one of the premier meetings, of course, but I would say it's a blessing in disguise that the physical meeting was not possible this year, because most of the Indian delegates, when they go to a European meeting, they would not be seen inside the meeting. They would be rather seen in the city somewhere. So you have at least the opportunity of looking at the presentation virtually, and you will be forced to actually look at and listen to the presentation rather than being out in the fashion city, as Dr. Kher described Milan to be. Now, the other thing is that even though this is an India-specific meeting, but I'm going to really talk about global challenges. But I think most of the global challenges that we will discuss are quite relevant to India. And I'm really very, very happy to share my thoughts with you. So the first thing to say is that the three major societies of the world, the American Society of Nephrology, the European Renal Association, and the ISN, put together a panel of experts, and they came up with this estimate that there are about 850 million people worldwide who have some form of kidney disease. Now, if you were to compare with the population of Europe, the population of Europe is actually less than the number of people who have kidney disease in the world. The other thing which is relevant to kidney disease is now the third fastest growing cause of death in the world, so much so that by the time the year 2040 rolls along, chronic kidney disease will become the fifth leading cause of death in the world. The other thing is that we know it in a subliminal way, but it has not been explicitly stated until we did this meta-analysis which we published in the Lancet about 5 years back. And we counted the number of individuals who were receiving kidney replacement therapy around the world. And we found that about 2.6 million people were receiving dialysis or transplantation in the year 2010. But what was an embarrassing truth which became very apparent, that almost the same number of people had died in the same year without having any access to dialysis or transplantation. Subsequent analysis by the Global Burden of Disease study published in the Kidney International Journal 2018, which showed that the kidney disease burden is actually highest in the least developed countries of the world. So you can see this global map on which the burden of chronic kidney disease is shown in different colors. And I would like to draw your attention to the different shades of brown, orange, and red. The redder you see the map to be, the greater the burden. And you can see where is the greatest burden. The greatest burden is in Africa, the poorest continent of the world, in some parts of the Middle East with some poor countries, and in some parts of Central America. India also is a medium burden country. And this burden is going to increase further in these parts of the world. So the burden is growing fastest where the resources are the lowest. The same paper that I described to you, 2015 paper, we looked at the prevalence of patients who were receiving kidney replacement therapy. And what this slide shows on the graph on the right-hand side, that about 93% of the people who were on dialysis in the year 2010 belonged to either a high-income country or an upper middle income country. The lower middle income country contributed only 6% of the global dialysis population, to which India belongs. What is the reason, you would ask? And I think it is not a surprise that the reason is cost. We also did this analysis for the World Bank, and we found that about 188 million people experienced catastrophic healthcare expenditure every year as a result of treatment for kidney disease in low and middle income countries. And this number is greater than the number for any other disease condition. We know that dialysis is expensive. The cost of dialysis is shown here, about $35,000 to $100,000 per year in different countries. But what is really, again, a known fact is that it is unaffordable for governments in many parts of the world. This slide shows you data from Africa. And what I would like to highlight is data in this box, where it shows that just about 1% of all patients who started dialysis in Africa continued dialysis for 1 year at least. So 99% of the patients either died or dropped out from dialysis. This is data from India, from the state of and basically the summary of this showed that of about 900 patients surveyed, 90% reported that their households experienced catastrophic healthcare expenditure, and about 3/4, which is 77%, engaged in distress financing. What is distress financing? It is selling property, taking loan, etc. Those are the kind of things. So in summary, these are the major barriers to end-stage kidney failure treatment in low middle-income countries. One is the shortage of nephrologists, nurses, dialysis technicians. Second is the shortage of funding. The third is the shortage of diagnostics. It may not be apparent to many of us, but serum creatinine testing and urine protein testing is not available in many low-income countries. Shortage of medications is well known, especially the more expensive medications. And finally, many of the low-income countries, low middle-income countries, do not have any policy to deal with kidney disease burden. Now, I will cut to the chase, and this COVID-19 crisis has also shown us that the dialysis population really indicates how our healthcare system is faring. In a sense, it acts as the canary in the coal mine, which is used to find if that coal mine is full of toxic gas. So when the COVID-19 crisis hit, apart from the people who were either directly developing COVID or were locked down because of COVID, the people with kidney failure, especially those who were on dialysis, were the first one to be noticed to be struggling for access to healthcare services. And this tweet on the right-hand side shows you the very first report in which a patient who was on regular dialysis died, in fact, because he was not able to get dialysis because he could not get access to getting a COVID test report because the dialysis unit insisted. As many of the dialysis units are doing now, quite justifiably, I would say, but then at that time, testing was so scarce that this patient was unable to get testing despite going from hospital to hospital and died as a result. Subsequently, there have been a large number of deaths reported, and a number of Indian nephrologists published a paper in the Kidney International Reports last year that showed how patients stopped reporting for their regular dialysis in many dialysis centers across the country. So if we were to, as a community, identify some principles of kidney replacement therapy as a part of developing an integrated kidney care framework, what should we do? I think we will all agree that even though we are talking of dialysis, our focus needs to be in preventing progression of kidney disease, and that it should always be prioritized. We also need to develop a sustainable model to fund kidney care, and we should not expect the patients to meet with the cost of care from their own pockets. The third bullet point talks about a way to manage patients with kidney disease we don't emphasize so much in India, which is conservative kidney management. Many patients, it has been recognized now in the Western world, would not necessarily benefit from being on dialysis, even though they have end-stage kidney failure. And those people should be offered conservative kidney care in which symptom control and alleviation of distress is the main goal. Then once we have done that, we should define very clearly what is the eligibility for access to kidney replacement therapy, and whatever criteria are developed, they should be applied in a transparent, consistent, and equitable manner. They should not be applied as they are often done in a country like India, where a phone call from a bureaucrat or from a minister decides who should go on dialysis. Kidney transplant program should always be prioritized for those who are suitable for kidney transplantation. And low-income countries that are trying to develop kidney replacement therapy should undertake a systematic study of what is the most cost-effective way of delivering dialysis. It could turn out to be peritoneal dialysis, as was the case found in Thailand and Indonesia. Those countries have made, in fact, a PD-first policy, right? So this slide really shows you the summary of the integrated kidney failure pathways. A patient with kidney disease starts from this point in his or her journey. by having a risk factor, developing kidney disease, eventually developing kidney failure, and then some of them will go on to receive treatment. And the treatment is divided into 3 buckets: comprehensive conservative care, dialysis, and again, dialysis is hemodialysis as well as peritoneal dialysis, and then transplantation. It's very important to actually also pay attention to these arrows, because they tell us that one or the other form of kidney replacement therapy is not an end in itself, but it is a cycle, and patients move from one form of treatment to another form of treatment. This is another way of depicting the, not really the pyramid, but the pathway of developing end-stage kidney disease care. Even though we talk of dialysis, and dialysis is perhaps the bread and butter of almost all nephrologists, we shouldn't forget the principles of public health by starting with what is called primordial prevention. And that will require us to achieve a really overall improvement in health, which are linked to sustainable development goals that have been defined by the United Nations and were accepted by most countries, or almost all countries, in the year 2016. So, but this is going to take 50 years and will not happen perhaps in the lifetime of most of us. Until that comes along, we have to focus on screening, early detection, and prevention of chronic kidney disease, delaying chronic kidney disease progression in those who have early stage kidney disease, and management of complications. And this can happen only if we focus on improving access to primary health care and by providing universal health coverage to all our populations. Unfortunately, despite all these efforts, many of the people will deteriorate. They need to receive appropriate pre-ESRD care, prepare for kidney replacement therapy, have a discussion about modality of kidney replacement therapy, identify those who are suitable for kidney transplantation, identify those who cannot benefit from any kind of dialysis so that they can be offered conservative kidney management. And of course, we are all very familiar with the 3 main kidney replacement therapy modalities. Now, to develop comprehensive supportive care, we in India need to develop kidney supportive care facilities. It is important for those who focus on patients who receive dialysis, because many of the patients who will require kidney supportive care will come out of the current dialysis population, because as they progress on dialysis, they will become frail, they will develop multiple comorbidities, and they will no longer do well on dialysis. So this is the pathway that we need to focus on. What also needs to happen is for us to recognize that management of kidney disease is a pathway, which starts from home and from community setting, where in community setting, there is a risk factor identification, health education, screening, use of point of care tests, and monitoring whether the patient is adhering to appropriate treatment or not. And home management is strongly linked to management at the primary healthcare center. Patients may require to be referred appropriately to district hospitals for certain tasks, such as diagnostic tests, for advanced investigations, for care planning, and in less frequent situations, they will need to go to referral hospitals, where they might require specialized diagnostic procedures like kidney biopsy or a vascular access repair. Maybe they might require a more informed discussion about ESRD modality choice. They will be evaluated and referred for transplantation. Difficult vascular access, PD access might be created there. They might need to come to a referral hospital for medical management and dialysis access related problems. Post-transplant care will most likely happen only at referral hospitals. And please do remember again this link between various types of kidney replacement therapy, peritoneal dialysis, hemodialysis, kidney transplantation here is on the right, and on top, kidney supportive care. All this needs to be integrated by someone, and we often think ourselves as a nephrologist to be omnipotent, but we need to empower our non-physician healthcare workers like nurses, like community healthcare workers, who should play an increased role in monitoring of the patient's health and in care coordination. But all of this needs to happen under a very strong governance, policy, and financial oversight. So we do require regulators. And I would like to end by saying that if we don't regulate ourselves, then regulation will be imposed upon us. And that is the time we start often protesting. But we have to remember that that situation arose only because as a community, and this is not to identify just one or two people, but as the entire medical community, nephrology community, this onus of developing a responsible care pathway falls upon us. I would like to stop here. Thank you very much, and I'm happy to take any questions.